Okay. Happy Tuesday, everybody. Hope you're having a good day so far. So today we're going to talk about arthropod bites and stings. There's a wide variety of this, some serious, some not so serious. Maybe some of this has happened to you. We'll talk about common things. We'll talk about treatment, and we'll talk about what you can do to mitigate serious consequences. So let's see what we got. Just by way of introduction, arthropods, very, very prominent in the world. 75% of all known biological organisms, about 1 million species. Today we're going to talk about insects, spiders, ticks, mites, and scorpions. 1 million different types. Some that we probably haven't even described yet. So for those of you that are interested in this, you can get out there and have one named after you. And estimated at 10 quintillion insects alive. That's a big number. So we'll start off with a case. So this is a 40-year-old male presented to the clinic in New Mexico, so Southwest USA, complaining of severe abdominal pain, cramping of 24 hours duration associated with diaphoresis, low-grade fever, and anorexia. Anorexia, loss of appetite, right? What's a fever again? What's the number for a fever in Fahrenheit? 100.4. 100.4. Symptoms began about an hour after suffering a scrotal bite from some unknown insect while hiking and camping around the Four Corners region of the Southwest. That's the junction of Utah, Colorado, Arizona, and New Mexico. So he got bit in the scrotum. That sounds no fun. Physical examination. Yes, that is his scrotum you see there. A little bit reddened, a bite site, severe pain and distress. So when you do your physical exam and you document your physical exam, there's a sequence that you do it in. So you start off with general or constitution, like what do they look like when you first see them? So 40-year-old person, severe pain. You want to try and describe it so that the person that is listening to you present the case or reading your clinical notes can get a visual picture of what this person looked like. So rocking side to side in the fetal position. A note, do people with appendicitis rock around on the stretcher? No, they want to lay still. Remember, their peritoneum is irritated. Movement causes them pain. One question I ask people that have a potential appendicitis, I say, does it hurt when you drove down? If you hit a bump in the car, in the road, or you went through a pothole, did that hurt? They say no. That means there's probably no peritoneal irritation. Another trick I'll do sometimes, I'll go up to the stretcher and I'll pump the stretcher and rock the stretcher. If that elicits pain, that's a subtle way of finding peritoneal, describing peritoneal symptoms. So we look at the vital signs. Remember, normal heart rate up to about 100. So patient's tachycardic, respiratory rate elevated at 40, temperature 100.4, right on the border of a fever, and mildly hypertensive. By the way, people that present to you in some degree of distress, it's not unusual for them to have a mildly elevated blood pressure. You've heard that term, white coat syndrome. Some people are very scared of medical personnel. They're afraid they're going to get a shot or something like that. So their blood pressure will go up just due to anxiety. Lungs are clear, cardiovascular, regular rate and rhythm. You'll write that in your notes. RRR, regular rate and rhythm. And S1, S2 means normal heart sounds. S1, S2. Normally, you also write no murmurs, gallops, or rubs. No, you put the negative, MGR. You describe the abdominal exam, severe diffuse abdominal tenderness with rebound and guarding. Certainly seems like peritoneal irritation, right? Because rebound means when you push in and let go, that causes some pain. Just of note, patients with renal colic or colicky type pain from either biliary colic or renal colic will often be writhing around on the stretcher. They'll be the ones that are like this. They can't get comfortable. They won't sit still on the bed, versus an appendicitis or a diverticulitis. They're usually lying still. Patient's diaphoretic. He's got good peripheral pulses, normal color, no focal deficits in neuro exam. So we get bit by something. Any thoughts on what this might be? Scorpion, possible. Southwest USA. Black Widow, we hear, oh, somebody's been watching Kill Bill. Okay, so first let's look at the lab data here. White count, 19.4 thousand. What I say is normal? 4,000 to 10,000 is roughly normal. So he's got a leukocytosis or an elevated white blood cell count. H&H is hemoglobin and hematocrit. That's 15 hemoglobin, 45 hematocrit. That's very good. That's normal. Remember, hemoglobin normal between 12 and 15. So that's good. Platelet count of 313,000. Anything over 150,000 is normal. Platelet counts are 150 to 400 in that range. Lights, meaning electrolytes, Na, sodium, normal 140, potassium 4, chloride 110, bicarbonate 23, all normal. So he doesn't have any electrolyte abnormalities, no signs of acidosis. BUN and creatinine, 15 over 0.9. That's acceptable. You might say a little bit dry. You look for a 10-to-1 ratio. That's about a 15-to-1 ratio. Once you get to 20-to-1 ratio, that's probably a fair amount of dehydration. Glucose of 150, mildly elevated, but it's not a fasting glucose. So 150 could just be due to some stress, or maybe he was anorexic, so he probably didn't eat. But that could just be due to some stress. Lipase, what is the lipase a marker of? We talked about it last week, pancreatitis, remember? Sometimes when you're assessing for pancreatitis, you order an amylase and a lipase. I think lipase is more sensitive, and LFTs within normal limits. So no evidence. So again, somebody with belly pain, normal lipase, normal LFTs. So you've kind of excluded pancreatitis as a cause. Patients with pancreatitis, by the way, are very uncomfortable. They're moving around a lot on the stretcher. KUB, do you know what that stands for? It's an X-ray. Kidneys, ureters, and bladder, KUB. It's two views. It's basically a big shot of the abdomen, an AP shot, and then one that's focused down a little bit lower. When you're looking for signs of obstruction, you order an X-ray that's called a flat and upright. So you do a flat plate, and then you do one with them sitting up on the stretcher or standing up. You're looking for air fluid levels in the bowel. So this is a little bit different than if you were looking for an obstruction series. No free air. What's free air indicative of? A perforated viscus, right? So on an upright X-ray, and it has to be an upright. If somebody's laying flat, you're not going to really be able to see free air. So it has to be an upright X-ray, and you look for a thin outlining of the diaphragm. That's free air under the diaphragm. Unless there's a reason for it, unless they've recently had some kind of laparoscopic procedure where they insufflate CO2 in the abdomen, you should not see free air in the abdomen. You should not see any evidence of free air. And urinalysis shows no white cells or red cells. So who said black widow spider? I think it was Lenore over there, right? So anyway, this is what a black widow spider looks like. That red hourglass on its thorax is pathognomonic for a black widow spider. What do black widow spider females do to their male after they're done copulation? Eat them. And why do they eat them? They eat them because that will increase the likelihood of survival of the eggs. It's basically nutrition. So the male goes down and sacrifices himself for the good of his offspring. So they bring in the spider. By the way, if you ever try to retrieve something that bit a colleague of yours, you don't have to go capture it. Just take a picture of it with your phone. All right. We've had cases of people who have gotten hurt trying to get the snake that bit somebody or try and trap it. And what's the likelihood that they're actually going to be able to get it without macerating it into a little puddle of spider body? So they captured the spider. He's given calcium gluconate. What does calcium gluconate do? Relaxes the muscles, calcium gluconate, and he's given morphine without pain relief. The doctor who's Have anybody seen that movie? It's a funny movie. Okay, so black widow spiders, or that family of spiders, are ubiquitous about the world. Just by way of example, you have the flame black widow. You have the redback spider, Southeast Asia, Australia, New Zealand. Only the female redback bite is dangerous. Antivenoms are available in endemic areas for these. Generally, pain will increase over time, sweating, muscular weakness. Ice pack is good. Capture or take a photo of a spider if you're traveling and you get bit by something and you don't know what it is or you think it's one of these. Do not apply a pressure bandage. Ice packs are good. I don't know. You would think it might help control spread of it, but it may actually increase local necrosis. But I'm not 100% sure. Mediterranean black widow. The bites can be fatal in rare cases. The people that are most susceptible to this are people that are frail, the frail elderly, or small babies that because of the dose of venom that they receive. There's a white widow spider, Middle East, Russia, North Africa. Not as toxic, but it can kill children and the infirmed. Okay, so a little bit quickly about the anatomy. 8 legs, 8 eyes, fangs, spinnerets. They have that red hourglass configuration. They really bite you as a feeding. They will bite their prey as a feeding, but they'll also do it as a defensive mechanism. The mating female may devour the male counterpart unless he gets away right away. Happens about 50% of the time. The venom will cause the release of neurotransmitters, norepinephrine, acetylcholine, and GABA. It's going to cause degeneration of the neurologic end plates and the motor end plates and an influx of sodium, severe muscle spasm. So they'll present with, they may have erythema at the bite site, neuropathy of the feet, burning on the soles of the feet, abdominal rigidity, agitated, diaphoretic, salivation, almost like a cholinergic storm. Cholinergic storms, that's where you get lacrimation, diaphoresis, vomitus, diarrhea, all from cholinergic storm. That's typically what you might see in some of the pesticides if somebody ingests a pesticide or has a pesticide exposure. That's called a cholinergic storm. So you're going to give them a tetanus. Whenever anybody's got a bite or some kind of unknown puncture wound, just always check their tetanus status. If it's been more than 5 years and it's a dirty wound, you should probably update their tetanus. If somebody's never had a tetanus immunization in their life or you're not sure, you can't confirm it, then you have to give them passive immunization with something called hypertet. So that's tetanus immune globulin. So you give them tetanus immune globulin and you start the vaccination series of a regular tetanus toxoid. Nowadays, just so you know, we don't just give tetanus toxoid. We used to give DT, diphtheria and tetanus. Now we give Tdap, which includes pertussis as well, because pertussis is making a little bit of a comeback. So the antivenom is common in areas where these spiders are endemic. Any of these antivenoms, you can get a serum sickness and bad allergic reactions to. Sometimes the cure can be almost worse than the what you're giving it for. So serum sickness is something that can be pretty dangerous. If you're not sure, you may want to do a pre-treatment and skin sensitive, but usually in these cases, you don't have time for that. Again, extremes of age, patients with frail cardiac situations, you'd be more likely to vaccinate them. Okay, so that's black widow spider. Second case number 2, 39-year-old male presents to the ED with a large sole on the back of his thigh. He claims the lesion has become progressively worse over about 48 hours. Also complains of a low-grade fever, generalized myalgias, arthralgias, denies any history of trauma, normally healthy, no diabetes. If you see this, area in the photograph here, someone drew with a pen around that area. Whenever you're assessing somebody for a cellulitis, skin infection, or any type of redness or warmth in an extremity, it's good to demarcate the border or the edge of that. So when you recheck them in 12 or 24 hours, you know whether they're responding to treatment or whether it's progressing. So usually in lower extremity cellulitis, which is probably the most common area for cellulitis, we'll outline the most proximal part of the cellulitis with a little marker or pen, and then we'll begin treatment, and then in 24 hours reassess to see if treatment is improving that or worsening it. What do you call it when you have a red streak that's coming up from a cellulitic area, coming up maybe the inner thigh? That's called lymphangitis. You'll see that. It's very easy to see when it's there. You'll see an area of cellulitis, and then you'll see a red streak, usually following some type of lymphatic drainage. More common in the lower extremities, but you can also see them in the upper extremities. So this person got bit by something, having some systemic symptoms, mild, really, but it's local redness. Progresses pretty quickly to this necrotic area. I'm not sure why it says he's in no distress. I'd be in distress if I had this going on in my leg. Pulse is regular, non-tachycardic, blood pressure, good. Got a little bit of a temperature, 101. Lungs, cardiac exam, normal. He's got this necrotic wound in his right thigh, a black eschar. Eschar is essentially a scab, and surrounding erythema. No local lymphadenopathy. Remember, lymphadenopathy, it's going to drain proximally, so you'd be checking for groin or groin lymph nodes in this case. No drainage, no lymphadenopathy, good peripheral pulses. Usually, if you have a cellulitis that looks like this, you're going to have some reactive lymphadenopathy. So something's a little funny about this one. Blood count, white count elevated, H&H, normal, platelets, little bit of thrombocytopenia, low platelet count. Remember we said 150,000, 120, so a little bit low. Not that you're going to get into any bleeding problems with a platelet count of 120. You really don't get into significant bleeding complications until usually the platelet count is below 50,000, 30,000, 20,000. That's when you start getting into some spontaneous bleeding. Coagulation studies, PTT and PT, those are both mildly elevated, and the INR is elevated at 2.1. Upper limits of that is about 1.5. When we put people on Coumadin for coagulation, for anticoagulation, for let's say atrial fibrillation, we want it between 2 and 4. So this person's somewhat anticoagulated, secondary to whatever that bite was from. Remember the BUN and creatinine? I said the ratio of 10 to 1 is about normal. That's 29 to 1.5 or 1.4. So this patient's a little bit volume contracted, a little bit depleted, a little volume depleted, and the urine is dip positive for blood. That could be blood. It could be hemolysis. It could be myoglobin. Remember yesterday we said myoglobin will dip positive for blood. Remember, if the urine dips positive on the little dipstick and it shows that it's blood, but then you spin it down, look under a microscope, if there's no blood, that just means it's globin, and it's from either myoglobin or hemolysis, hemoglobin in the body. Admitted, diagnosis of cellulitis, they say. They start them on some antibiotics. They call the surgeons to maybe debride this wound. Heals 2 weeks later with chronic scarring requiring skin grafting. So this was the brown recluse spider. Again, common in the United States, common in the Southwest USA. These are, by virtue of its name, recluse. They kind of hide. They're not really out to get you. But if you're in an area where they feel threatened by you, or you should startle them, let's say you sit down near a nest or something like that, you could get bit. They have this characteristic marking on their thorax. It looks like a fiddle. You can see it here on the right. Looks like a kind of an upside down violin or fiddle as compared to the hourglass of the black widow spider. They're reclusive. They're nocturnal hunters. They'll only bite when they're threatened. So this is what it will look like a couple of weeks after the bite, causing necrosis at the bite site. that eschar formation, some circumferential erythema. Generally, it's going to stay as a local reaction. These things will ulcerate over about a 2-week period of time, and then usually anywhere between 4 to 6 weeks, they will spontaneously heal. You will give the patient antibiotics, but it's not like a cellulitis. It's really more of a chemical reaction to the venom. And again, as we said before, small people, elderly people, more susceptible to the not necrotic effects of this. You can have systemic findings, a little bit of hemolysis there. You can see the blood looks like hemolysis, thrombocytopenia, hematuria, blood in the urine rather, convulsions. You can get a lot of symptoms, systemic symptoms, but again, probably 85% of the time it's just local symptomatology. Same thing, tetanus, you can give antihistamines, for antibiotics, steroids don't help. Leukocyte inhibitors, dapsone will sometimes be used. Hyperbaric oxygen to accelerate healing. Really, you don't need to get the surgeons involved. This is not something that you need to debride. Analgesics, you can give heparin if the patient has systemic signs of disseminated intravascular coagulation. You may have to give packed red blood cells or platelet transfusion if they become very anemic. If they go into renal failure, you need to do emergent dialysis. It's not lifelong dialysis. It's usually just temporizing. Antivenom is available in South America, not commercially available in the US. This may be an older slide, so it may be available as of now. And you can buy these over-the-counter antivenom healing bombs. You can get this on Amazon. I'll have to add that to my armamentarium. Probably the best thing is to make sure that if you're in an area in your home and you see these, you should probably protect yourself by spraying the areas. And if you're camping out and you leave your shoes outside the tent, or you leave some clothing out, or your sleeping bag, before you put your foot into your shoe or your body in your sleeping bag, you should shake it out. Because these things go in there and they want to nest in there. They want a nice, cozy, warm spot. So always, if you leave your shoes outside, just turn them over, whack them a couple of times. Nothing is worse than sticking your shoe in your foot in your hiking boot and getting bit on the big toe. There's other type of necrotizing spiders. I won't read them for you, but you can see them. Particularly the jumping spider seems a little scary to me because they can jump. And the wolf spider, it sounds a little bit nasty. We'll quickly go over a few of these. And you can see in the United States, they're pretty much located throughout the entirety of the United States. That red color is the brown recluse spider. The gray is the other recluse species, not the brown recluse, and that greenish up in the northwest, hobo spiders. Just some schematics of a couple of those. You don't need to know all of these, just to show you that there's more than one. The brown recluse is the most well-known and probably the most common, but there's these other ones. These are all necrotizing spiders. Daddy longlegs are benign. The American house spider is benign. Jumping spider looks pretty nasty, but he's really not particularly dangerous. I don't know. I don't want him to bite me, though. The yellow sac spider, the grass spider. So these are pretty common in the United States, and they're not particularly dangerous. We got, can you play this? A lot of research on spiders here.
The wood spider is the most accomplished of all web-building species. Recently, scientists gave these tiny creatures a variety of psychoactive drugs to observe their effects on web building. When given a minute dose of LSD, the spider's web took on an unfamiliar, minimalist structure. When given caffeine, the web structure was not affected, but the spider's behavior was. Given THC, the active ingredient in marijuana, the spider didn't build a web. It built a hammock, where it lay all day and watched the caffeine spider go. When given alcohol, the spider built a web, found a mate, and raised over 100 young. But the mate got a restraining order, and now the spider can't go within 100 centimeters of the web. The crack cocaine spider figured building webs was for suckers, waited till the caffeine spider was exhausted, then came up behind it and popped a cap in its ass.
So a lot
Nice
of
web, Mr. Crack Spider. When winter came, the marijuana spider had no place to live. It ended up in the crack web as the crack spider's bitch. For more information
So a
on the
lot of
crack
research
spider's
going
bitch,
on with spiders, obviously, and a lot more to be learned. By the way, these are all on YouTube. So there's no, I'm not pilfering anybody's stuff here. Okay. Tarantulas. Let's go. Tarantulas. Are they dangerous? I guess to their prey, they're dangerous, but they're not particularly dangerous to us. They don't really have much of a toxin in them. They're the largest of spiders. The hair on them can give you an allergic urticarial reaction, but they're generally not particularly dangerous. Largest of spiders. They burrow. Has anybody ever, I don't know, have a friend who had a tarantula? Yeah, probably a good idea. So we were in, there you go. Yeah, and they'll hold them in their hand. They're not particularly dangerous. It's very weird. We were in, I think we were in Panama or something like that. And we were out on a night hike, and the guy showed us where they nest. There was kind of in a little cave in the side of a little overhang, and they just kind of sit there waiting for their prey to come by. But other than that, they're really not particularly aggressive. They have a venom which is toxic to smaller prey for them. Tarantulas all around the world. They're actually pretty cool looking. This Goliath bird eater tarantula, look at the size of that thing. The largest tarantula in the world. They live in the deep rainforest of South America. Thailand, Malaysian blue femur earth tiger. Wow. So they have things that will attack them. If you familiar with the tarantula hawk wasp? Play the tape.
Meet the tarantula hawk. It's a parasitic wasp that has no fear of massive spiders. The female wasp is armed with a venomous sting that can paralyze a spider in seconds. And
I'm
now
more scared of the
things
wasp
get
than
nasty. She drags the helpless spider into its own burrow. Then she lays a single egg on the spider's abdomen and seals the chamber. When it hatches, the larva sticks its head into the paralyzed spider and sucks on tarantula juices, avoiding the vital organs to keep its host alive for as long as possible. Eventually, only the tarantula's withered husk will remain, forever buried in its lonely grave.
It's a cruel world out there. Very cruel world. Okay, so there's a lot of spiders. That's a pretty cool looking one on the left there. There's rumors that when you're sleeping, spiders crawl into your mouth and that you can ingest spiders in your sleep. I'm not sure if it's true or not. There's a lot of spiders there. People who snore or mouth breathe, there's certainly spiders could be curious. I'm not going to do this site because it's a couple of minutes. It's on the what have you, but there's really no proven evidence that spiders crawl into your mouth. But that doesn't mean you don't eat bugs. And I'm not talking about swallowing a bug while you're jogging. We may eat up to 2 pounds of insects or insect parts every year without knowing about it. Vegetables, rice, beer, pasta, spinach, broccoli. The United States Food and Drug Administration has allowable insect parts per certain food types. Kind of scary. Your beer made from hops can contain up to 2,500 aphids per 10 grams of hops. It's not going to mean you have to stop drinking beer. Just be aware that you're getting some protein in that beer. Orange juice can contain up to 5 fruit flies, 50 aphids or mites, plus caterpillar larvae, and 3.5 ounces of frozen spinach. So make sure you are rinsing your food well. But again, I don't think there's anything particularly harmful with these doses there, but just know that you're getting some protein. Okay, we got another case here. Somebody mentioned a scorpion before in that one case. So this is a 30-year-old female, presents to the ER in Singapore from a local restaurant after they were stung by hundreds of light brown scorpions, which escaped when the chef opened several heads of imported lettuce. The patient is anxious and hyperactive with tachycardia, hypertension, muscle spasms, and roving eye movements. Roving eye movements are disconjugant eye movements. Your left eye's going to the left, your right eye's going to the right. They're all over the place, up and down. Restlessness, anxiety, secondary to a scorpion bite, hypersalivation, again, similar to that cholinergic symptoms that we talked about. Dysphagia, difficulty swallowing. Dyspnea is shortness of breath. Bladder and bowel incontinence. Remember, we said that with the cholinergic, you get increased lacrimation, salivation, hyperemesis, diarrhea, disconjugant roving eye movements, and hyperthermia, elevated temperature. You're going to apply ice to the bite site, support vital signs with intravenous fluids, monitor respiratory status, supplemental oxygen if needed, update the tetanus all the time. You can treat the anxiety and the hyperactivity with benzodiazepines, analgesics, calcium gluconate, again, for those muscle spasms they may be having, opioids. Diphenhydramine is an antihistamine. There is an antivenom to scorpion. It's made from, derived from goats, available in Arizona, Mexico. You can, as we said before, any of these antivenoms, you can get a serum sickness. I had a lady, she had never been vaccinated, or she had never had her primary tetanus immunization. She came in after a wooden splinter, a dirty wooden splinter in her foot. And she came in with a very, very bad infection. The person who saw her in the emergency room prior to me seeing her gave her a regular tetanus shot and some antibiotics, but she had never had her primary immunization. So she came back in about 10 days later with a continued infection in the foot and with systemic signs of tetany, muscle spasm. We've then got a better history, and we found out that she had come to this country maybe when she was 30, so had never gone through primary tetanus immunization. She got the hypertet. It ended up, the amount she had to get, the tetanus immune globulin, she had to get about, it's weight-based, she had to get about 9 or 10 shots, massive load of tetanus immune globulin. She survived in the ICU for about 2 weeks. But she ended up dying as a result of severe serum sickness from the immune globulin. So always, 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 if you're not sure about tetanus status, clarify it or give them an initial dose of immune globulin hypertet. The amount we had to give her, because she had already signs of Clostridial tetanus toxoid, we had to give her a very, very large amount. When you giving it to them prophylactically at the initiation of it's a relatively small amount. Serum sickness is not as bad. We gave her so much that she got deathly ill from it. So this is maybe on that same trip we were. So this is at nighttime with a flash, taking a picture of a scorpion that we saw by the trail. And then we turned off the lights, and our guide had a woods lamp or a blue light, put it on, and it fluoresced that you can see right here. It's not unique to scorpions. A lot of arthropods and insects will fluoresce with a woods light. Might be a good thing to take if you're going on if you're going to be doing some hiking in the Amazon and you're going to be doing some night excursions, just looking for stuff. A woods light, you can buy those on Amazon. It's called a pet urine detector. It's a little flashlight that's a blue light, and it'll light these things up. Plenty of scorpions out there. Okay, we'll shift gears. We'll do a little bit of bees because this is probably the most common insect that we have allergic reactions to. There's different families of these. There's wasps, there's bees, there's ants. All of them can have toxic effects. Bees are going to cause the most allergic reactions. Females are capable of multiple stings, local pain, redness, swelling, local versus toxic versus anaphylaxis. You can just get a local redness. You can get some systemic symptoms, or you can have a full-blown anaphylaxis. Delayed reaction, again, you can get a serum sickness with stings from Hymenoptera. Female sting, but only once. So these are the wasps and the hornets. These ones here, they can give you multiple stings. The bees that you sting here, the females are the only ones that sting, and when they do that, they avulse their stinger out of their thorax and they die. So you can only get stung once by this middle group. And then the ants on the right, we'll talk a little bit about them. The one that we all know about is the fire ant, the red fire ant. If you've ever been bit by those, you would remember it. We'll show you a little bit what those look like. When you're out and you get swarmed on by the bald-faced hornet, they will bite you multiple times, or sting you rather, multiple times, and it hurts like a bandit there. These are the Africanized killer bees. It's a hybrid of the western honeybee. They bred them to probably make more honey or something like that. They were introduced in Brazil in 1956 in an effort to increase honey production, but swarms escaped from quarantine in the late 1950s. Now they're all over South America, and they're working their way up through Central America into North America. There's been reported 1,000 humans that have been killed by the African killer bees, and usually they're able to sting multiple times, killed horses, other animals. So they're very dangerous. And one of the reasons why they're much more dangerous, not only the potency of their venom, but they will swarm and they are very aggressive. Some bees, if you go near their nest, or wasps, if you go near their nest, if you run away and you're maybe 10 or 20 yards away from them, they leave you alone and they go back to, these ones will chase you for hundreds of yards. Fire ants, the red fire ants, these are the ones that you'll see along the path, little piles of sand. You see them all over Florida, southern United States. Very, very painful bite at the time of the bite. They're painful. Local burning sensation followed by urticaria, some little hives around the area. Swells into a papule. A papule are these little white looking areas here. That's really not pus. It's just inflammatory. It's not infection. It's inflammatory fluid. They're actually sterile. You don't want to go popping these things with a needle or anything like that. You don't need to drain those. They'll develop into these white pustules within about a day or so. They can become infected if you're scratching and opening them. You're best off just leaving them be. You don't need to unroof them. It'll spontaneously flatten and desquamate after a couple of days. Antihistamines and a little bit of topical steroids. So remember yesterday we were talking about things that you take with you when you're traveling. We've heard a lot about antihistamines. You should always take antihistamines with you. Topical corticosteroids. I think maybe here there's a slide somewhere in here about the potency. When you buy over-the-counter 2% hydrocortisone, that's about as weak as you can get. If you're going to take a hydrocortisone or a cortisone type cream, you should take probably something that's prescription strength or a little bit stronger if you're going to be traveling. That's the bald-faced hornet. We won't show that particular one. Very aggressive, attack anything that's near their space. They'll have these big things. You'll see these hanging from tree branches when you're hiking sometimes. Just keep your distance from those, all right? Local treatment with ice, elevation. You can get really, 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 really sick from these big loads of it. You can have anaphylaxis. You're going to need epinephrine. We'll talk a little bit about epinephrine, which is basically adrenaline. H2 blockers. H2 blockers are like Pepcid, Protonix, things for the stomach. Those are histamine 2 blocker specific. General antihistamines like Benadryl they'll attach to H1 and H2 receptors. So we'll usually give Epi. We'll give Reglan or one of these other H2 blockers. We'll give antihistamines and steroids, but as soon as they come into the emergency room. Okay, we'll switch to tick-borne illness because there's quite a bit here. We'll try and finish on time for you guys. So on the left here, this is the typical Lyme rash that you see. What's that one called? What's that rash called? ECM, erythema chronicum migrans. ECM. It's a bullseye. You'll see some redness in the middle, and then you'll get clearing and then a red ring on the outside. Probably about 75% of patients who get Lyme will have a rash. Another 20 to 25%, they're not going to be able to remember or recall a rash. Means it could have been on the scalp. It could be an area that was on their back that they didn't see, and they don't come and see you till they're having systemic symptoms. I've probably had Lyme 2 or 3 times. Now, when I have a tick on me, that I live in the northeast, when I have a tick on me that I know is kind of on there pretty good, and it's been on there for a while. Let's say I was hiking yesterday and I found it this morning in the shower or something. I'll take 200 milligrams of doxycycline right off the get-go. I don't even wait for any symptoms. 1 dose of doxycycline, 200 milligrams, that will keep me from getting Lyme disease. But that EM, erythema migrans, is the rash that you see with Lyme disease. You treat this with 21, either 3 to 4 weeks of doxycycline is the most effective treatment. We used to say don't give doxycycline to kids under the age of like 8 or 12 because it can cause some staining of the teeth, and we have to treat them with amoxicillin. That's kind of by the wayside. Now we can give doxycycline to kids because they found that really wasn't clinically significant. Anaplasmosis is another type of tick-borne illness. This does not have a typical rash. These are the people that'll come in with fever, 104, chills, severe headache. A lot of times these people get worked up for meningitis because they got fever, chills, and a bad headache. Sounds like maybe similar to meningitis. By the way, rule of thumb, you have somebody who looks sick, high fever, headache, plus or minus neck stiffness, you got to think meningitis. If you think meningitis and you don't have another reason why they should be having it, you absolutely 100% need to do a spinal tap. If you think about it and you don't have another reason for why somebody has these symptoms, you need to do a spinal tap. Blood count's going to show a little bit of a drop in their H&H. Most prominent is thrombocytopenia. These people come in with platelet counts of 100, 110,000. So thrombocytopenia. So when these people come in, we'll get LFTs and we'll get a blood count on them. Usually see a little bit of elevation in their liver function tests, specifically their transaminases. If untreated, it can progress to respiratory failure, coagulopathy, organ failure, and death. Again, treat it with doxycycline. Put this one in your bag when you're traveling. Doxycycline is one of the more preferred antibiotics to have with you because it can also treat some of the intestinal infections and diarrheal illnesses you would get. So salt tablets, antihistamines, some type of topical cortisone or steroids, probably also oral prednisone or some Decadron or something. I like traveling with Decadron, smaller tablets, and they'll last in your system for maybe 72 hours. Prednisone is maybe 24 hours. Again, 14 to 21 days. I'd probably lean towards treating for 21 days with this. And you can do testing for specifically anaplasmosis. Just because you have Lyme doesn't mean you can't have anaplasmosis, or just because you have anaplasmosis doesn't mean you can get Lyme. Babesiosis is another tick-borne illness. It's caused by a parasite that lives in the tick. It's a flu-like illness similar to malaria. You can get very, very sick, cause hemolysis. The blood smear, I think we have a picture of this later on, gives the blood smear in the red blood cells will cause a Maltese cross design in there. You can probably see it. I think it's on the next slide here. You can do PCR testing for all of these. That one is not responsive to doxycycline. You need to treat them with 2 medications or maybe 3 medications. Severely ill people, clindamycin and quinine. Remember what I said about clindamycin, Cleocin? 10% of the people can get a C. diff colitis on that. So be mindful of that with clindamycin. It's a great drug. For people that are pen allergic, that maybe have intraoral infections, we use clindamycin a lot, but you can get some side effects with it. C. diff. Ehrlichiosis is another tick-borne illness. Similar, flu-like illness, fever, chills, bad headache, myalgias. You can do a PCR test for this, again, treated by doxycycline. So for most of the tick-borne illnesses, with the exception of babesiosis, doxycycline is what you can treat them with. Rocky Mountain spotted fever, caused by a spirochete carried by a tick, again, can be pretty sick. They have a rash, usually on the hands and feet, edema around the eyes, back of the hands. They can get very sick. You can die from Rocky Mountain spotted fever untreated. Doxycycline or tetracycline to treat that. A lot of joint pain associated with Rocky Mountain spotted fever. It's not isolated to the Rocky Mountains. You can get this in eastern U.S. along the Carolinas. Francisella tularemia is another tick-borne illness. The rabbit is a vector for that, and it's called rabbit fever. Signs and symptoms vary depending on how the bacteremia enters the body. Life-threatening, accompanied by high fever. Treated with different antibiotics, streptomycin, gentamicin, doxycycline, Cipro. So a little bit different. So again, doxycycline you're going to have in your bag. These are other tick-borne problems. We talked about most of these. Probably the most common: anaplasmosis, ehrlichiosis, Lyme disease, Rocky Mountain spotted fever. There are some other things that are caused by toxins, not necessarily infection. This tick paralysis caused by a toxin. Colorado tick fever is going to give you a high fever. So you can see ticks you can get pretty sick from ticks. Again, just a schematic showing all those things we talked about. This is what let's see if we can get this. In that anaplasma, these are red cells you see for the most part here. I'm sorry, you can't really see this real well. You'll see that on the smear. I'm looking for babesia. You'll get these intracellular staining that'll occur in babesiosis. And again, most of these treated with doxy, except babesiosis, you need to bump it up. That's the nest of the I think those are the African killer bees. We talked a little bit about this. We don't need to do too much more. Okay, what's this kid got? Look at him. He's pretty swollen. What's probably going on with him? Pain, edema, erythema. He ran into this in the woods. Presents like that. So he's having an anaphylactic reaction to bee stings, probably the most common. What's the other most common anaphylactic reaction? Peanuts. By the way, I think we talked about this last week. We used to talk about not giving peanuts to children. Early exposure of peanuts to infants is going to reduce their risk of peanut allergies. So 1% of all stings, people will have anaphylactic reactions, mild to life-threatening, severe bronchospasm, hives, urticaria, vasomotor collapse, hypotension. Epinephrine is the treatment of choice, antihistamines, corticosteroids, and airway management. If you give somebody 1 dose of epinephrine, you start to get a response. You are not done. The epinephrine response will last about maybe 20 minutes. Sometimes they will require a second dose of epinephrine, even though they had a transient response. And those people that receive epinephrine for an anaphylactic reaction, they need to also get steroids because you can get a delayed reaction 6 to 12 hours later. So you need to give these people steroids. What does anaphylaxis do? It's going to cause swelling in your airway, occlude the airway. Patients who come in with anaphylaxis that are really sick, you need to secure an airway early on. If you wait till their tongue and their hypopharynx, their uvula, their airways all swollen, it's very difficult to intubate these people. So if somebody's going down the tubes quickly, they're having more and more respiratory distress, stridor, you've given them epinephrine, they're not getting better, you better secure that airway. Otherwise, that's going to lead to some severe complications. Also, low blood pressure. You need to give these people a lot of volume. Again, normal saline, 2 liters, wide open. Anybody that you've given epinephrine and steroids to, you need to watch them for a couple of hours because they can have a rebound and get sick again. You need to discharge them with an EpiPen. These are the typical EpiPens. There's an adult and there's a junior EpiPen, 0.3 milligrams of 1 to 1,000 versus 0.15 of 1 to 1,000. These EpiPens actually, if you are traveling and you're going to be kind of the medical person on any expedition, you should have an EpiPen with you, or at least some epinephrine that you can give somebody subcutaneous. These EpiPens actually have 3 doses in them. You can only use them once, but you can break these open, and there's a spring-loaded cartridge in there. It's got enough for 3 doses. It's got 1 ml. You're only using 0.3 milligrams, but it has 1 full milligram in the little container. I was at a workshop, a wilderness medicine workshop, and the guy had the EpiPens, and he was showing us how you could break them open. There's a little cartridge in there, and you can actually get 3 doses out of it. So if you're going to be on an expedition and there's people that may have allergies or what have you, and you're the medical lead, you should tell them to make sure they have their EpiPen with them, or you should have one in your kit. Again, we talked about the biphasic reaction. You give them epinephrine early on. You also got to give them steroids because they're going to have a late reaction. You can treat these people with immunotherapy to mitigate these severe anaphylactic reactions. A couple miscellaneous ones. Chiggers, they live in the grass or wooded area. They're going to affect your waist, your bra line, topical creams, lotion, calamine like a drying agent. Diphenhydramine is the Benadryl. And you can give permethrin or as an antiparasitic. Cold compresses, cleaning the area. Bed bugs, a lot of talk about that most recently over the last couple of years. You don't want to get bed bugs. It's not so much the bite. It's not an infection from the bite. There's this tremendous inflammatory response to the bed bugs. Lots and lots of inflammation, itching, blisters. They'll disappear on their own within a week or 2. You can ease the symptoms with topical steroids, oral antihistamines. If you're traveling and you're sleeping in hostels or something like that, you got to be a little careful with this because so some people will travel, they'll bring their own little like it's like a liner for a sleeping bag that they'll sleep in. Scabies, they're a burrowing type of infestation of the skin. It's a pretty typical looking. First of all, scabies are very, very itchy, very, very itchy, very pruritic, and it's a burrowing serpentitious line. So you'll see them in the intertriginous, the wrist folds, the elbow, the axilla, the groin. They burrow, they lay their eggs under your skin. Intense itching, pimple-like rash. Permethrin is treatment of choice. Sometimes you have to treat them more than once. Okay, what is that again? We're just a recap here. What is that? Herpes simplex, close, but it's fire ants. Remember the fire ant bites, little pustules. Should you pop those? No, leave them be. Cool compress, ice, antihistamines. Probably you don't need to use a topical steroid, but it might help with some of the inflammatory. What's that? Somebody got bit. That's day 5, progressing. Day 23, that big escar. What was the spider? Not the black widow. Remember, the black widows gives you the abdominal symptoms, right? That's the brown recluse. Should we call the surgeon for this? No. Treat him probably with some antibiotics and you follow along. What's that one? What do we call that rash? ECM, erythema chronicum migrans. It's from Lyme. Bullseye. I had a guy one time, he came in, it was the entire size of his back. It was probably as big as a full-size Frisbee on his back with central clearing and a ring. Pretty typical. Actually, can I tell your story? Yeah, my wife, where'd you have the rash? I forget. Linda and I hike a lot at home, and she was having, I think your first symptom was hip pain. She was having pain in her hip, and very unusual because normally we will walk a lot, no problems. And then she ended up having a bullseye rash on her forearm. We were traveling, were we coming down? We were going somewhere, and I actually had to get a wheelchair in the airport to get her onto the plane. But within about 5 days of doxycycline, the rash cleared and the hip pain resolved. We kept 28 days. 28 days. We didn't even do any blood tests because we figured it's got to be Lyme. So that's a Lyme rash. What's that kid got? He got stung by the swing set, so he's having an anaphylactic reaction. What do we treat him with? Epinephrine. Epinephrine is life-saving. Steroids. Why do we give them steroids? Because of a rebound. You give them epinephrine, 6 to 8 to 12 hours later, they can have a rebound. What do we always send them home from the ER with? Prescription for an EpiPen. Okay, because if it happened once, it can happen again. And sometimes the second time is worse than the first. This guy was hiking along the Appalachian Trail in North Carolina, started having fever, headache, myalgias, temperature 104. Notice this rash. What was it? Rocky Mountain spotted fever. What did we treat him with? You go to the pharmacy, you say, doctor, our pharmacist, do you have any doxycycline? He says, no, we're all out. What else could I treat him with? Tetracycline. Doxycycline, tetracycline. What's that one? I didn't tell you this one. People always come in with this and they say, I think I got bit by a spider. I think I got bit by a spider. And you look at it and they say, well, I don't know. Maybe he got bit by a spider. Why do you think he got bit by a spider? Well, I saw a spider in my house. And then they got this, but then they got a couple of these in an area. That's MRSA, methicillin-resistant Staph aureus. I can't tell you how many times I've had people with MRSA infections come in and they say they got bit by a spider. Nothing to do with a spider. They got a skin infection, a MRSA skin infection. A lot of times these will present with an abscess. You need to drain it. You need to culture it. If you adequately drain a MRSA abscess and you get good drainage, sometimes they really don't even need antibiotics. We still give them antibiotics, but a lot of times they don't even need it, just proper drainage. What are the antibiotics of choice? Remember, the cephalosporins and the penicillins don't work. So what do we treat MRSA with? You can treat them with vancomycin. That's a big gun. Usually you need ID approval for vancomycin because now they're becoming more vancomycin resistant. So Bactrim works, sulfa will work. About 10% of the population has sulfa allergies, by the way. So Bactrim will work, trimethoprim sulfa. Doxycycline will work. That clindamycin will work on these. And vancomycin will also work. So nowadays, if I'm not sure if somebody has MRSA and they're coming in with a skin infection and it looks like maybe they have some little abscess or little, pustular areas, I'm going to probably treat them with something, assuming that it's MRSA till proven otherwise. So I'll usually give them, I've changed my practice. Now I'll give Bactrim for a skin infection. Two of my daughters are dermatologists, but one of them, she treats these all with doxycycline. So again, doxycycline is a good med to have. Bactrim's a good med to have in your little travel kit as well too. Good for UTIs. It's good for some of the GI things that you can get. So Bactrim, trimethoprim sulfa is a good one to have also. That was that Maltese cross one, that other tick-borne illness. It wasn't Lyme. It wasn't, what was it? Babesiosis. And you don't treat that with doxy. It's a combination of two meds, quinine and clindamycin, or I don't know, a Torva something. So that one you're going to treat a little bit differently. Serpentigious burrowing infection. Itches like a mother. Scabies. Yeah, that one itches. In between the fingers, you see them in the wrist. We get these a lot of time where people come into the ER, maybe you get somebody who's homeless or, down on their luck or living on the street. They'll be coming in for one thing and they'll have this. And if you miss it, you send them up to the inpatient unit. Oh my God, you get hell for that because now everybody that's come in contact with that person has to go on prophylactic permethrin. Okay, and we got one last one, and this is, I guess the moral of the story is you got to look because you never know what you're going to find sometimes.
Guys, I'm not even joking. We just covered it up with Vaseline, and then this thing's trying to get out my head. There's a botfly living in my head right now. I think I might actually pass out right now.
Stop, I'm the one who has to look at it.
This is so funny.
I'm literally syringing your head.
As if she's putting gloves on. It's not medical school. Just come on.
Oh my God.
What?
It is huge.
Don't.
Oh my God.
Oh!
Oh my God, Tom. Tom, grab that container quick.
Please just calm about it.
Oh my God, Tom.
Whoa!
Oh my God, Tom, is it alive?
So that's the larvae of a bot fly. The fly basically laid its larvae in the guy's scalp.
Oh, is that in your hair? I can't.
So that would really be weird to have that in your scalp. But you'll see that people have a lump on their head. They may have traveled in an area. You saw that there was Vaseline or the hair was like slicked back. Sometimes people do that to try and smother it, take the oxygen, because there's a little breath hole at the top of that little area there where the larvae can breathe. So sometimes people will, if they can't do this, they'll put Vaseline over it to try and kill it and then pull it out. But yeah, that's pretty weird. The other thing we use Vaseline on the hair with, if you have, just as a sidebar thing, if you have somebody who has scalp lacerations or an eyebrow laceration, never shave an eyebrow if you're suturing somebody's face. Sometimes they don't grow back. It's a different type of hair follicle. On the scalp, sometimes we'll use bacitracin or Vaseline to just plaster the hair down so that you can get at the wound to repair it. You don't need to shave people's heads to repair a head laceration or, cut their hair. You can just slick it back with either Vaseline or bacitracin ointment so you can expose the wound and repair it, and they'll thank you for that. We're not going to do snakes in this one because we're way past time, but there's a couple of interesting clips here on snake bites. This is available on the school website, some of these things. So if you want to just flick to those, go to the end. Those are some pretty cool little video things. I go to this course it's in Big Sky, Montana. It's Wilderness Medicine course. And a lot of the people that material and video clips that I'll show in some of these talks are people that speak at that conference. And particularly the guy who does the snakes, he's absolutely phenomenal. So these are each about 5-minute little clips. You may want to watch those on your own time if you have a little downtime, you want something entertaining. Pardon? So on the school website, these talks are streaming live, and they will also be available later on. So you can click and just fast forward to the end, and these URLs are embedded in there. Actually, why don't you just, if you got, these are 5 minutes, just play, you want to play the first one?
Today
This
we're
is the
talking with Tim
website,
Erickson.
Wilderness Medicine.
We're
They're
here
all
at
on
the
YouTube.
Santa Fe National Conference on Wilderness and Travel Medicine. Tim is a professor of emergency medicine and toxicology at the University of Illinois and a specialist on snake bites. So we have a few questions for Timothy. First of all, thanks for coming out to Midwild.
It's great to be here. Beautiful weather, and can't beat the setting.
Is this a common scenario where people are bitten, just hikers out in the wilderness, and suddenly a snake jumps out of a tree and bites them?
It's not as common as people would like to think, but certainly in the setting here in the Southwest, New Mexico, Arizona, Utah, you are going to get snake bites, pit vipers, predominantly rattlesnakes, Mojaves, Western diamondbacks. So if you're rummaging around, you're hiking, you're going into brush off trail, yeah, you're susceptible to snakes. Now, they're not going to stalk you. They're not going to come flying out of trees. They're not like anacondas that are going to devour you, but they are going to strike if disturbed. So if you step on them, reach over a log, they may strike. They'd rather leave you alone. They're poikilotherms, cold-blooded. They'd rather just sit still, absorb the heat, and not waste their venom on humans. They'd much rather have rodents, rabbits, etc. The people we are treating really are those that are messing with snakes. They're taking chances. They have pet rattlesnakes. They're a little intoxicated, and usually they're males, so they got testicles. And yes, sometimes testicles are bitten. But these are the type of patients we get, the ones that are messing, pushing the limit, not the ones that are hiking out on a trail. If you're just respecting it, staying on trail, certainly if you're going to go off into the bush, blaze your own trail, then you're asking for it because you may inadvertently step on one, and then it's going to defend itself.
When you're hiking along, what are you thinking about in terms of prevention?
Well, first, I'm on another planet. I'm never thinking much, but prevention-wise, stay on the trail, make a little noise, give the snakes a chance to crawl away, and they will. If you see one directly on the trail, respect it, go around it. Usually you're going to be fine. So know that they're there, respect their habitat. They don't want to encounter you. They don't want to mess with you. And usually you'll just be fine. Now, there's certain snakes internationally that are a little more pugnacious and will go after you, the mambas, the cobras.
In your experience, how often do you see snake bites that result in no envenomation at all?
It's called a
It's
dry
actually
bite.
quite often. If it's a non-venomous snake, like a garter snake,
I'm
a
assuming
hog
a venomous snake.
Okay, if it's a venomous snake, about a third, even 40% will be a dry bite. Again, snakes don't want to waste venom on humans. They can't devour a human. They'll strike, realize it's not a small rat, rodent, and will draw back. So you'll get envenomated, you'll see puncture wounds, but there won't be the poison injected into the victim. So you'll get a dry bite, you'll feel pain, but you won't see the manifestations of the bite, swelling of the arm, leg, blistering. You may be hysterical because you think you're going to die, but the vast majority won't die, and quite a large amount, again, a third, it's a dry bite.
In a lot of first aid books and even wilderness medicine books, there's a suggestion that if somebody's bitten by a presumed venomous snake, that they should somehow bring that snake with them to the emergency room so that it can be identified. How do you feel about that?
Not necessary. If you're in a habitat, a natural setting, you are going to know what type snakes are indigenous to the area. And they're going to be treated the same. So to send the victim back into the bush, or you yourself trying to save the day to wrestle the big anaconda or the venomous Mojave rattler, makes no sense. You're going to get harmed. You're going to harm the staff trying to care for the patient. Let it be. Let it retreat. You're going to treat it the same. Same anti-venom covers all the snakes that are indigenous to the area. The only exception is if, again, someone's messing with the snakes and it's an exotic international snake, that's a different story. You may want to identify it. Otherwise, off the trail, in the wilderness, leave it be. We're going to treat it the same.
Sometimes people presume that when they're hiking, and if they're careful and observant, that they'll hear a rattlesnake rattle before it bites. Would you agree with that?
No. Classically, it's not going to rattle until you're almost on top of it. It will retreat. It's not going to be rattling left and right, warning you. It's usually once they're intimidated, they're defending themselves, you're in their territory. So just because you don't hear a rattle doesn't mean there are not snakes around. So you have to be cautious. Don't use that as a barometer whether there's snakes, whether it's safe to go off trail.
We've been talking a lot about local snakes.
Correct. Yeah.
What about people that are doing adventure travel? They're traveling internationally. Is there anything that they should keep in mind?
Yeah, we're used to seeing pit vipers, rattlesnakes, blood, hematotoxic snakes. When they go internationally, they're going to see more neurotoxic snakes like cobras and kraits, and they may look different. So you may say, hey, I know what a rattlesnake looks like. I know the shape of its head, diamondback, those elliptical eyes. Snakes internationally may be round-eyed, they may be small, they may have no rattles. They could be more venomous, more dangerous than our snakes that are indigenous to the U.S. The best thing to do, unless you know what you're doing, stay away from them. Trust your local guides. Even internationally, please stay on the trail. They're there for a reason. Don't mess with Mother Nature. Don't mess with the snakes. Leave them be, and we can all get along, and it'll be a beautiful planet, Howard.
Oh. Just let me just see. Can you go back to the presentation? I think I have. Okay, I don't have it. There's no value in lancing a snake bite and sucking the venom out. No value in that. You have more bacteria in your mouth, and you're much more likely to cause a secondary infection at the bite site. So if somebody who's got a dry bite and you go ahead and lance that with your pocket knife and start sucking out the blood and venom, they're likely going to get an infection from your mouth. So don't bother to do that. I won't show you the second one, but you keep the keep the person calm. You don't want them to get agitated. You call for help if you have a cell phone and you're in the area. If not, you try and remove that person from the area so they can get help. In our hospital, we didn't have the anti-venom present. Again, I'm in the Northeast. We do have rattlesnakes there. There's cottonmouths. There's other poisonous snakes. We didn't have the anti-venom in our pharmacy, but the local poison control had a variety of anti-venoms that were available that we could send for and get. Also, the Bronx Zoo wasn't far from us, and they have a lot of different anti-venoms because they have a lot of these other exotics. So sometimes you actually have to go to contact your local poison control and they will know the location of all these various anti-venoms and options for you. But again, you can see these are all, there's great YouTube clips on emergency medicine and wilderness medicine. And these folks that do this in that course, that conference, very knowledgeable. And there's a lot of these little 3 to 5 minute little clips online for that. All right, we'll stop here. So we have a couple of things this week. We have some venomous sea creature, a talk on that. We have some backcountry orthopedics and reduction type of stuff, wilderness medicine orthopedics, and 1 or 2 other ones. And then maybe on Friday, we'll have a little fun and do like a little wrap up questions and little competition, a little trivia game or something like that. Say again. Oh yeah, we're going to do internal medicine roundtable, right? At 2:00. Is that in here? Okay, I think Michael or Mikhail is going to be coordinate that. So that'll be 2:00 on Friday, internal medicine roundtable, and kind of just have a discussion of some of the things that are happening out there. Okay, you guys have a great afternoon, great evening.